Welcome to the fifth episode of the weekly monthly clinical lecture series organized by the Doctors Welfare Society of LRH. Initially, we had common ENT disorders in children. Then we had common skin disorders. Then we moved on to common eye disorders. Then we had a very interesting lecture on asthma last month. And today we are moving on to neurology. Today our topic is Floppy Baby, which will be conducted by Dr. Anuruddha Padeniya, consultant pediatric neurologist of Ridgeway Hospital for Children. Dear sir, over to you to conduct your valuable lecture. Thank you.
First of all, I would like to thank Dr. Vasan and the LRH team for inviting me to do this important lecture. And the topic which I was given was the floppy baby or floppy infant actually. And this is a very important topic. Basically, this topic covers almost all aspects of neurology. We'll start the lecture. I think I wish you will be able to concentrate this floppy baby. I'm going to start this lecture from the basics of what is this hypotonia. So we will discuss what is this muscle tone and all about, and then we will learn how we should demonstrate hypotonia. And once you demonstrate hypotonia, it's very clear that we developed a floppy baby, practical approach to the floppy baby. And then what are the conditions, and within the limited time, we will be able to touch a couple of conditions that will be important for you to understand. So first of all, we will understand what this muscle tone is. Now, all of you all know that we have a muscle tone. So why do we think that we should have a muscle tone? If you really analyze it, what is the reason that you should have a muscle tone? What is muscle tone? Basically, so the muscle tone is now when you don't have the muscle tone, like when you are in anesthetized state, what happens? If your hand drops down, it falls down. But when you are alert, but in a rest, it won't happen. So basically, the muscle tone is the definition is the resistance to the passive stretch, not the active stretch, and it's physiologically directed to safeguard your posture and the balance. So that is very important. So it is the, by definition, so the muscle tone is the resistance to the passive stretch. So whenever you are not in the active state, when you are sleeping, if your hand drops down from the bed, it will have a resistance which will be generated by this muscle tone. And that's a very important activity in our body, especially to maintain our balance. Now I am standing here, all this passive stretch without my consciousness is being maintained. That is why I am standing here. Otherwise, if the tone is not adequately maintained and that balance is not there, I will not be able to stand here and I will not be able to maintain my balance. So it's very important. So who are the elements that are involved in this process? Obviously, there should be a sensor. Now, to read the passive stretch, there should be a sensor. So the sensor comes that is living in the muscle itself. We call it muscle spindle. Then it should direct the spinal cord, and there should be a reflex activity. At the same time, it will go up to the brain and there will be another circuits working in the brain. So all these three elements are involved, and then with that input, there will be output down to the muscle to maintain the tone as it maintain the posture and the balance. So when that is not adequately maintained, we call it hypotonia. When it is over, we call it hypertonia. We call it spasticity. There are various types, the rigid type or other types of spasticity. And when the whole control is not in proper order, we call it dystonia or paratonia. So these are the basic aspects that you can. So apart from the normal tone you are maintaining, you can have hypotonia when the tone is less, or it will go up, or it can get deranged. So these are the elements that involved. You can see the muscle is involved. So in the muscle, you have the muscle fibers to contract and to reduce the length and then to make the necessary movement. So within that, there are a set of muscle spindles to read in what status of the tone we are maintaining the muscle. So there are, that is called the sensory element of the tone. Then it will be relayed to the spinal cord through the sensory pathways, and from there it will be the reflex will go back to the muscle. So there is a supraspinal control also, we will see. So this is the element that you can see the extrafusal fibers which maintains the activity of the muscle. At the same time, we call it the intrafusal fibers, which are linked up with the sensory organ in order to get the sense of in what state the muscle is at the moment lying. So with that, ultimately what will happen is that the sense will go up to the posterior aspect of the spinal cord, and it will be the reflex activity will come back to the muscle, and that will maintain the passive resistance of the muscle. So that is the that is what you mean by the muscle tone. So the muscle tone, much more diagrammatic presentation of it. So you can see the extrafusal fibers and the intrafusal fibers, which are all wired with the sensory organs, sensory systems to read. At the same time, when the muscle is stretched like that, there will be overstretching also. The passive stretching might go over. To read that, you have the Golgi tendon in the tendon. So if it is going beyond the required tone, what will happen is the Golgi tendon will make in an inhibitory pattern to maintain the tone. So you can see there's a tone maintenance. At the same time, if the tone goes up, the Golgi tendon will work in the other direction to have a negative impact. So all in all, the tone of the muscle is a measure of muscle resistance to the stretching while in the resting or the passive state of a body. So the contraction is basically on the extrafusal fiber, that is the active part of it. And the intrafusal fibers are the kind of sensory elements to record it down to the spinal cord. And this asynchronous discharge of the motor neurons will ultimately give not only the spinal cord to the supraspinal level to the brain. So the mechanism which is maintained by the myotactic reflex, what I explained is that, but at the same time, I told you there is an inverse myotactic reflex by the Golgi tendon down there to maintain or to control if it is going beyond the expected level. So there is a active as well as the, positive as well as the negative role in order to maintain the balance. So the muscle spindle is doing in from a point of view, the explanation point is the excitatory role is played by the muscle spindle, and ultimately the Golgi tendon body is maintaining the inhibitory part. So this is the balance that we are playing in order to maintain the balance between the tone. So how the muscle tone is in upper motor neuron and lower motor neuron. I told you what happens is you have a supraspinal level activity also. If that direction is not there, what will happen is the muscle tone will be, the negative muscle tone is coming, negative inputs are coming from top. So because of that, if that is not there, what will happen is there will be hypertonia. So the upper motor neuron usually have the spasticity, but whereas if the complete pathway is blocked or damaged, then what will happen is you have a complete flaccid paralysis. Not only the tone will go down. So then you call it the low motor neuron type. So that is how you bring the nerves in. But the tone is, maintaining tone is up to the muscle to maintain. So muscle is being directed by the supraspinal as well as the spinal level. If the supraspinal level maintenance is not there, there will be tone will go up because the inhibitory part will be removed, and ultimately you have the upper motor neuron type where you, when you tap and when you elicit, there will be exaggerated reflexes because of the high tone. But if the pathway connected from spinal cord to the muscle is not functioning, obviously there won't be sensory motor, both pathways will go down and there will be lower motor neuron type of activity. So it is reflected in a picture like this. You can see it comes to the spinal cord when it is, now it will be like this, the muscle. Now what will happen is, now muscle is stretched like the passive stretch will be like this. Now that will be reflected or the sensory pathway when it will connected to the spinal cord, and that will be relayed to the brain as well. Then the motor pathway starts, and then the tone will be maintained. And if it is going beyond the expected tone, the Golgi tendon will come into play to maintain the tone at that level. It is complex, but I think you will understand this simple principle before you go into the hypertonia. The role and the importance of muscle tone. Why? So very importantly, it maintains our normal posture without our knowledge. And it's we call it involuntary, it's happening. And not only that, even during the movement, not only you are still low when you are in the not in move, even when you are moving, that will guard against the danger and help to maintain the balance right throughout. So maintaining the posture as well as the movement, both has a element to play with the muscle tone. So how are you going to clinically demonstrate? This is very important. Now, in the process of clinically demonstrating myotonia, there can be mistakes. So how are you going to, especially for registrars and the senior registrars here, should ideally understand how you are going to demonstrate the hypertonia from a very smooth process. Because hypertonic child, when you carry, the parents will not like, they collapse, not like, because the reflex resistive or the safe mechanisms are not in proper operation. So therefore, there can be, when you pull out the hands, their neck will go down. Then the mothers and the people who are watching you might get irritated if you don't really practice the maneuver properly. So the clinical demonstration of hypertonia has had to start after 32 weeks because before 32 weeks, anyway, they are in a hypertonic state. So ideal weight is the age POA is considered as 32 weeks, but beyond that, there will be, might not be able to see the slides, but 32 weeks is the level that you can start demonstrating hypertonia in a correct manner. So the history, you have to get the history from the mother and the maternal records. I will go into later. And then the most important thing is we are going to observe the child, the hypertonic posture. So we'll see what are the elements that you have to confidently say that child is hypertonia when the child is in the posture as well as to the movements. So there are 4 elements which are listed on the demonstration of hypertonia, that is pull to sit. We call it then to demonstrate the head lag, and then the ventral suspension, which will give the picture of the red doll appearance. Then the vertical suspension to demonstrate the slip through process, and then the calf sign. So these are the 4 elements. I think we have to demonstrate in order as a registrar for you to reflect that the child has hypertonia. So how to suspect? So obviously you can have the history where can be delayed second stage of labor or maternal, it can relate with the maternal myopathies. Or maternal medications or drugs is very important that you need to cover. Then the congenital infection, you know, the torch screens and other things are linked up with this. Then the perinatal infection, then the feeding difficulties and the cry. So those are the initial elements, and then subsequently you might have respiratory difficulties as well. So in the maternal record, it's your duty to have a look into the quality of the fetal movements and the quality of the polyhydramnios, oligohydramnios, and then whether the child was breech delivery and there had been perinatal insults during the process and the delivery complications, and how the hypoxia caused pH and the ABGA. And postnatal also, whether what complications had led to this status is very important. So the clinical observation has 2 elements, that is the posture and the movement. So you can see a normal child is seated properly, and compared to that, there is a C-shape or inverted C-shape curve here, and the child can't maintain the normal posture as compared to a hypertonic child. So we call it the round back in the seating position. And when it is clinically demonstrating hypertonia, you can see the normal child, they are, the position they are maintaining, the knees are being flexed, hands are being adducted, but when it is hypertonia, you can see the legs are flexed and arms are adducted in the lying position. That's why I told you by before 32 weeks, the same picture may not be there. So therefore, after 32 weeks, we have a look into this. So this aspect is not there in a hypotonic child. You can see the flex, the position of the legs are not there and the adapted position of the hands are not there. So because of that, we call it the frog leg posture for the child. But for you to tell that it's a frog leg posture, what are the key points that you are going to analyze? So reduce spontaneous movements and you will be able to observe, and legs are fully abducted and they are lying on hands on the either side. So how are you going to demonstrate hypotonia? The first point is that the head lag to be demonstrated by pull to sit. So how are you going to do that? When you are going to pull, there won't be any resistance from the neck muscles. So there will be head lag and there won't be any flexion of the hand. So when you are going to see the video in a moment, to observe what will happen to the legs and the neck. See the neck, see the legs, right? This. Then head pause. Clear? So what you need to observe in the head, the head lag, and then you might have observed the leg positions, and then when you raise up, the neck will fall onto the forward drop will happen. So that is. Next one is the ventral suspension. We'll see how it happens. So in the ventral suspension, you see the resistive mechanism is not there. So exactly see how the ventral suspension is done. So turn to the other side. Your hand is underneath. Then you can see the neck compared to his neck and how the leg compared to his legs. Right? Both the neck and the legs have to be. This is the second manual. Clear? So what you need to observe is that the head position compared to this here and the leg positions are maintained, and even the hands you can see, unlike here, it's not completely now. Here the hands are basically dropping down. So it's called ragdoll posture. Then you are going for a vertical suspension. So what you will do is we pull to sit, then you turn this thing, turn the child, and you demonstrate the ventral suspension. At the same time, you carry the child on a vertical suspension. Then what will happen? They will slip through. You can see. Now with the normal child, with the hands like this, here after the hands are going inwards and the legs are complete in the relaxed posture. So now 3 elements are touched. Next one is the scarf sign. So scarf sign, of course, you can have a look where the elbow is brought beyond the midline. So this is how we are going to demonstrate hypotonia clinically. Clear? Now going beyond the midline, that's called scarf size. Clear. So basically, I told you what you mean by tone and the importance of tone. But we are discussing hypotonia, not other types of hyper or dystonias. And now, once you demonstrate hypotonia, now you are very clear that this child has hypotonia. Now, the next line is, how are you going to develop a management approach or diagnostic approach to hypotonia? So that also we will develop carefully. Now, to do that, what you need to do is, the hypotonia can be, as I told you, from the upstairs, the brain and the spinal cord, as well as from the downstairs, the nerve head, nerve, neuromuscular junction, or from the muscle. So now you have to anatomically differentiate whether this hypotonia is because of the brain or the upper motor aspects or from the lower motor region. So how are you going to differentiate? So again, now I told you how to demonstrate the clinical feature of hypotonia. Now it is our time to demonstrate the weakness on top of hypotonia to see in what category that this child is going to fall. But I told you, if the supraspinal connection is being broken, what will happen is the tone will go up. So then there will be hypotonia, but they are strong. So we call it strong hypotonia. But if the supply to the muscle is completely shut, what will happen is child will be completely flaccid. So we call it weak hypotonia. So based on whether we have weakness or not on top of hypotonia, once you demonstrate hypotonia, we will be able to differentiate either path. Am I clear to that point here? So how are you going to demonstrate the weakness on top of hypotonia is the next discussion that we are going to have. So obviously the weakness is being demonstrated in your sense that you have 0 to 5 levels of analysis of the muscle power. But of course, this is the infant or hypotonic neonate. So therefore, we will not be able to do the resistance against and against gravity. So basically what we are going to do is to check the first part, whether there are no muscle movements, call it 0, or whether there are trace muscle movements or activation or twitches, or whether there are muscle movements against the gravity. So I think 0, 1, 2 are the 3 things that we will be able to do with a neonate and an infant, because we will not be able to assess the 3, 4, 5 level of muscle strength in a child. So how are we going to see that? First thing is the observation, and then how are you going to demonstrate it? So it is usually limited to observation to demonstrate the weakness on top of a hypotonia. So weakness, if the activities or his movements are very decreased or spontaneous movements are less, then of course we will be able to see whether this child is having weakness. And you can see the child's face, apart from the, sometimes they might have dysmorphic features, but leave aside the dysmorphic features. If the child has a V-shaped mouth, and then if you can open their eyes easily, and then if they are like wearing a mask without expression, facial expressions, then of course you might think that child is having weakness. On top of that, if the child's cry, you will be able to listen. And if the cry is very weak and in the process of feeding, if that is not established properly, so with these 5 elements, you will be able to judge or observe whether the child is having facial features of weakness. Am I clear? Then of course, you can observe the abdomen. If their respiratory muscles are not properly working, they will get the abdominal support from the diaphragm. So there will be abdominal breathing. So with all these features, we will be able to judge whether this child has weakness on top of hypotonia in order to differentiate anatomically in which path or before investigations. So then you take your knee hammer and you might check your reflexes. So what will happen is, if it is central hypotonia, or the central causes are there, then there will be hyperreflexia, but you will not be able to elicit reflexes if it is peripheral, and you might elicit fasciculations on the muscles when you tap there will be fasciculation, then there will be tongue fasciculations in order to confirm that whether we are dealing with hypotonia, whether it's the central causes or peripheral causes. Am I clear? That level? Yeah. So differentiation of hypotonia and the weakness. The weakness, infant always, weak infant always have hypotonia because the muscle, if the muscle is weak, whether the neural support is there or not, will be weaker. But if the muscles are doing well, and if the problem is with the nerve, what will happen is you can have two types of weaknesses, two types of hypotonias, weak hypotonia and the strong hypotonia. Understand? So this is what is published recently to indicate the weakness. They highlight 5 tests to demonstrate. Now I told you how we are going to demonstrate the hypotonia. Once you demonstrate the hypotonia, I told you how to suspect weakness by facial features and their movements and the abdominal respirations. Once you do that, you can see the indicators of the weakness is being highlighted. People call it the cough test. So what do you mean by cough test? When you stimulate them to have a cough, they will not be able to do the proper cough. Then there will be drooling, and there will be pooling of secretions of the mouth, and there will be weak cry and paradoxical breathing. So these are elements which are published to confidently say that this child has weakness. So now we have two elements, whether the child has floppy strong child or floppy weak. So hypotonia with without explosive movements, sprints, jumps, or with or without. Now we'll go to the causes of hypotonia. Now, basically, set of causes for floppy strong is not the same set of problems for the floppy weak. Now, usually when I am teaching neurology, I usually put the neurology system under 7 headings. You have the brain, number 1, then the cerebellum, number 2, then the spinal cord, number 3, then number 4 is the spinal head, as a nerve head, then the nerve is number 5, then the neuromuscular junction is the chemical element, is number 6, and then the muscle, number 7. So people think that the neurology is very difficult, but if you have a clarity in your neurology, what elements we are dealing, whether we are dealing with the brain, cerebellum, spinal cord, 3 elements, that is, we can call it upstairs. Then starting from the nerve head, number 4, then you have the nerve, number 5, then the neuromuscular junction to transfer that message down to the muscle, then number 7 is the muscle. For the management purposes, I take another 2 elements, that is the bulbar and then the sphincter. So 8 and the 9. Then certain conditions cannot be categorized under any of these 9 elements. So syndromes like conditions, so it's number 10. So if you put this neurology under these 10 elements and try to work out a diagnosis in the process of this kind of activities is very important, and you will have a clarity in your mind. You will not do all the tests in a neurology patient. I told you, first understanding the hypotonia, then demonstrating hypotonia clinically, then you have come to differentiate it whether 1, 2, 3 or 4, 5, 6 by floppy strong and floppy weak. That was done through the process of demonstrating weakness. Now we are in the process that which part of the neural system is in trouble is what we are going to trace. The central causes accounts for the majority of the hypotonia. You can see the list. So what are the other clinical features? So this is the spinal cord activities, brain, spinal cord. So what are the things we can list down? Now, brain, of course, before coming to the brain, if it is in the nerve head, you call it SMAs, spinal muscular atrophies. Then if it is in the nerve, you call it HSMA, hereditary motor sensory neuropathy. If it is in the neuromuscular junction, you call that set of problems myasthenic conditions. Then if it is in the muscle, either it is muscular dystrophy or myotonia or myopathies, is in the muscle. So these are the listed things under that heading. So these are the clinical clues that you can use. We'll go one by one. So central nervous system, motor neuron, nerve, neuromuscular junction, and muscle. Same classification, right? Now it's clear that we are going to hunt for a cause of the patient who had demonstrated hypotonia with or without weakness. Right. So what are the central nervous system causes? It can be chromosomal, metabolic conditions, and it can be hypoxic ischemic or perinatal damages, insults can be there. Then coming down to the neuromuscular junction, SMAs. When it comes to the nerve, you call it HSMN. Then it's the junction with the myasthenia that you are going to discuss. An acquired condition of infantile botulism. I'll talk to you in a moment. And then the muscle conditions. Clear? So evaluation of a floppy infant from the history. I told you initially also, you have to get into the family history. And then the perinatal history, and then prenatal, perinatal, and the neonatal histories. So central hypotonias, peripheral hypotonia, how are I going to differentiate from the history and the examination? Obviously, if it is a central causes, the child will be not having the normal alertness, and there will be depressed kind of alertness, and there may be dysmorphic features, and the facial gestures will not be, I told you the facial features initially will be absent, and then it's the most of the hypotonia is predominantly axial, and its abnormal development will be dealt with. The brain size, it will be unlikely to have microcephaly, it will be normocephaly usually. Then you are going to see the reflexes will be mainly usually exaggerated. But in terms of peripheral clues, child will be very alert, very alert. This is very important. Peripheral causes has no problem with the brain. So therefore, the child is very alert. And there won't be any organomegaly. And but the problem with the feeding, weak cry, and the respiration will be compromised. And mainly in the distal rather than the axial muscles. And the weakness will be very profound. There won't be, we call it weak hypotonia versus the strong hypotonia in the central causes. And when you are going to do the elicit the reflexes, there will be fasciculations more than the reflexes. So the same thing, the level of consciousness, side of the weakness, reflexes, and the power. These are the same elements that you will be able to use in order to differentiate whether we are dealing with the floppy strong or floppy weak. Am I clear? Same thing over and over again for you to understand the concept behind the whole thing. So floppy strong, I told you the same systems. Now you know what are the things that you are going to see. When you are going to investigate also, that will be directed to the brain. You might go and do the imagings. You might do the chromosomal karyotyping, and those we'll list them in a moment. And the floppy weak, of course, what will happen is we have to get the help of the neurophysiologist, because they are the people, the clinical, what we do is we observe, we neurophysiologically elicit certain features, but the extension of it is asking the neurophysiologist to see whether our findings are to confirm our findings, whether the nerves are functioning, whether the nerves are running their messages fast as normal, or if the nerves travel of the messages are slower, or whether there is you can use the EMG needle to see whether the muscle is normally functioning, or whether there is innervative issue, or whether there is a structural issue in the muscle. So that will be by the EMG. So you have the nerve conduction and the EMGs to see what element is in trouble. So the nerve conduction will prove whether we are dealing with the nerve which is not optimally functioning. So if there's a delay, or if the speed is slow, according to the nerve conduction, they might say there is a demyelination. So the myelin is very important to fast spread the message. And if there are axonal damages, the amplitude will go down on the nerve conduction study. But when you put the EMG needle, if the normal sound and the structure won't come, then the muscle architecture will be in trouble. So whether it is because of the nerve connection or not will be differentiated by looking into the nerve conduction combining with the EMGs. Am I clear? So with that point of view from the neurophysiologist, we will be able to see whether we are dealing with the what type of floppy weak. So in the floppy weak child, we have to differentiate whether we are dealing with the nerve head, nerve, neuromuscular junction, or the muscle. Clear? So how are you going to differentiate that? So floppy strong, hypotonia strong, central hypotonia. We'll finish that and come to the floppy weak. So obviously, hardly anything to teach audience like this. You all know about the hypoxic ischemic encephalopathy. The central pathways are not in proper optimum functioning. There can be insult to the brain, hemorrhages, chromosomal disorder, inborn errors of metabolism, neurometabolic disorders. Basically, to keep the brain optimum function in trouble, give rise to central hypotonia. So in the process of evaluation, we have to see the sepsis panel we have to do. And then the electrolytes, we have to obviously see whether there is the electrolyte imbalance causing this trouble. And then for the to look into the metabolic condition, you might do the urine investigations. Then you will see in examination the hepatomegaly and other whether there are any calcifications on the imaging in order for you to see the infection, including torch titers. And now, of course, even the genetic tests are available to evaluate the central hypotonia. And then you might extend yourself to do the karyotypings and other genetic studies like methylation for the Prader-Willi syndrome and or Angelman syndrome. And all these activities will be linked depending on that you are going to decide that we are dealing with floppy strong or hypotonia strong central hypotonias. And you might do this panel plasma amino acids and organic acids to see whether there are amino acidemias or organic acidemias or serum lactate. You might do carbohydrate metabolic problems, pyruvates and ammonia you might do for urea cycles, and acetyl carnitine profile you might do for lipid metabolic conditions, and very long fatty acid will be done for the paroxysmal disorders. This is a panel. So for you to do, depending on that you are suspecting metabolic conditions in this child. Then you might, this is for the floppy weak children muscle. And you might do imagings. So for the same reasons, the cycloencephaly, lysencephaly, and hydrancephaly. So these are elements that you are supposed to identify. So in the process of radiological evaluation, you might, based on the structural damage, you might see whether it is a vascular territory. You might think about vascular damages, or if it is non-vascular kind of damages, then you might think about mitochondrial abnormalities. And if the lesions are on the brain stem region, you might diagnose certain syndromes. So based on the MRI findings also, you might be able to narrow down your possibilities into the syndromic diagnosis. Very importantly, the correctable thing, the thyroxine levels had to be tested in these children. I think it is universally done at the moment, but sometimes I see patients who have missed doing thyroxine levels, and especially when they have jaundice, it's very important for you to see. And nowadays, the vitamin D levels have come into practice. So vitamin D levels are also being now tested, and there is a enthusiasm on the vitamin D levels. Right. The most important part and the learning part is not on the central hypotonias. How are you going to differentiate the hypotonia weak is what you all are very much concerned of. So I told you there are 4 elements, very easy, that whether it's the nerve head, nerve, neuromuscular junction, or whether we are dealing with muscle problem. Whether it's a transient one or whether it is a permanent one. Because that child has just come out from the mother, certain influence which is due to the mother, maternal delivery, might remain in the same. So that also should be in your mind when you are going to see the hypotonia weak. So what are the tests that you might do? The creatinine kinase, CPK. Now, when the CPK is usually in our labs gives around 300. So when it is 400 or so, sometimes you get agitated. No, at least it should be 5 times. So 1,500, 3,000. So that is the range that the CPKs are considered to be much abnormal. Then I told you the EMGs, just to check the muscle. Then the DNA testing and the muscle biopsies to some extent, but with this genetic testing now available, hardly muscle biopsies are done because genetically we will be able to take a blood sample and do the testing without doing surgically to take a piece of muscle from the body. The big process. So LMN lesions, obviously, again the same 4 sites. It's again and again I am telling you to get that confidence. Clear? So anterior horn cell diseases, then the neuropathies, then coming down neuromuscular junction problems, and then the muscle problems. So the distinct pattern of the weakness may favor the certain etiologies. So when there's axial weakness, usually towards the central hypotonia. When there's generalized body weakness with the alert face, what do you think? It may possibly we are dealing with anterior horn cell diseases, SMAs. Child is very alert. I'll show you videos. And then myasthenic syndromes, what will happen? More involvement of the bulbar oculomotor regions. That predilection, why it is there, it's not that clear. Because the problem is why this neuromuscular junction is only causing eyes and the bulbar region, not other region also can get affected in the generalized myasthenias. But you know, more predilection, why it is that? It's not that clear. That's why they are linking up with and trying to explain it, the timers and all, but there are limitations. Anyway, progressive muscle weakness can be attributed to sometimes dystrophic muscle, dystrophinopathies you call it. And then the other demonstration of proximal weakness include the lordotic posture, because when the proximal muscles are not supporting, they will compensate with the lordotic posture. Understand, when they are walking, when they walk into the clinic itself, but they are not the neonatal or infants, when they are much larger or when they are in the toddler stages, that will be obvious. Or when they are start walking, the Trendelenburg's or the Gower's sign will be able to reflect. Then when it is more into topographically into the face or arms or shoulders, the topographical distribution of the weakness might reflect whether we are dealing with what type of dystrophies that we are dealing with, the muscular dystrophy that we are dealing with. And especially when the distal muscle groups are affected, you can have that with peripheral neuropathies. As I told you, in this algorithm, usually to call it the high CPK levels, usually 5 to 10 times of CPK are being considered as abnormal rather than, because even if you can hit the child, or even if it is a injections and other muscle activities, the CPKs might go up, because that is leaking the creatinine phosphokinase from the muscle to the blood system, and that is being read by the blood test. So always we have to be cautious. And you can see the latest algorithm which is published, they say at least to consider CPK high should be in the round range of 10 times. So now we will start with the low motor neuron type couple of conditions. I have only another 10 minutes. We will just touch the spinal muscular atrophy and stop. So what is spinal muscular atrophy? This picture will basically reflect all the conditions. This is SMA0. You might be starting with SMA type 1. SMA0 was recently published in 1999 and by the Dubovitz, and he claims that there is a more serious compared to the SMA type 1. He tagged this as SMA type 0 or prenatal SMA, and they might be having certain features during the womb itself, and when they come, they will succumb and they might die sooner than the SMA type 1. So these are the two types of SMA that we are going to talk in the floppy baby syndrome. Others, of course, the type 2 also we can bring in under the children. And these are, of course, adult variations of SMAs, adults or adolescent variations. So spinal muscular atrophy, obviously, you have to understand the problem is in the muscle head, nerve head. And because of that, the supply channel, the entire nerve is getting atrophied. And then as a result, the muscle also will get atrophied. So you can see the nerve is getting damaged. So then the nerve is also get atrophied, and then the muscle is also. You can see in this picture what will happen to the muscle. So real time to come, the muscle will be weak and weaker in this condition, and they will not be able to function the muscles. So it is hypotonia with weakness. Understand? So weak hypotonia. Am I clear? Because the nerve head is the troublemaker there, and the muscle is actually the victim of it. Right? So the muscle is getting weak and weaker compared to on the time frame. So the supply, actually, it is in the spinal cord. You can see the child is very alert. This is the first child who had the benefit of getting this Nivli SMA been now treated with a very expensive drug. So this is the child who was first exposed or trialed with that drug. And you can see the child is very alert, but to maintain his cry and the respiration is not as it is expected to the very alert child of that nature. Am I clear? So child is alert, but he's weak, right? Because the upstairs function is very good, and so they are floppy, weak child. This one of my own child. You can see the this fasciculations on the tongue. I hope you'll appreciate that. It's not that easy, right? This child I referred back to Candy because, and so tongue fasciculations. You can see the nerve head is in trouble, so the muscle is getting atrophied. So SMA type 0, you can see since it is starting from the perinatal period, there can be certain contractures and other skeletal deformities, and they appreciate the this generalized osteopenia on these children. So these are the features which are highlighted under SMA type 0 compared to SMA type 1. So this child, I will demonstrate the clinical features of SMA. You can have a look. Now child is very alert. You can see, lovely child. And you can see the abdominal breathing, right? Abdominal breathing, right? Instead of the chest breathing. And see the chest shape. It's slowly getting a funnel shaped chest because of the breathing pattern. So abdominal breathing is nicely demonstrated there. When it is video from this end, you can see we'll appreciate the abdominal breathing very well. Clear? You have to get the confidence of detecting abdominal breathing because the child is alert. You might say child has nothing to worry by looking at the child, but child is in trouble. You can see nicely the abdominal breathing. Clear? So to explain to the parents that this child will not stay until their second birthday is not that easy task, because when you see this child and they ask whether they can do anything because the child doesn't look ill. Clear? You can see what happened to the chest. So you can say bell-shaped chest simply because of the respiratory is not by the respiratory muscles, by the abdomen. So slowly it will adapt to give a bell-shaped chest. So that feature will not come initially, but later on. So let's see this video as well. Floppy baby, you can see. So from the beginning, child is alert, but very floppy. So When you put in this posture, child is not raising their head. Then you can see the neck hypotonia, leg hypotonia, hand hypotonia, all three. Now you are very confident on these things after seeing the videos. See the hypotonia. So we have to very delicately handle these children because very important. Otherwise, the parents might think that you are careless. So when you are going to demonstrate and see that instead of moving the head, child is moving the eyes to see on eye. The child is not turning the head. Child is moving his eyes to see either side. Right? We want to have children. So you can see the abdominal breathing again. Child is so alert on respiratory compromise and see the hands they are keeping hypertonia demonstration. So all the features I have been telling over last 30 minutes, it's been clear. Now you can see the tongue fasciculations very well. There. Did you see? You want to see the video again? Last 6 months, we had about 5 SMA children coming. You notice that the tongue fasciculation? Yeah. So we'll get the, now once you get the, now clinically now you are very confident that you are dealing with SMA. Now the next problem is whether it is type 0, obviously very severe, 1, 2, 3, 4. Understand? So how are you going to differentiate that? Now, clinically, of course, SMA type 1 had to be differentiated with infantile botulism because what will happen here in the infants, their normal gut microbiome is not there. So when you eat something with botulinum toxin, the botulinum spores with the Clostridium botulinum toxin, what will happen is they will have constipation, lethargy, poor feeding, features in favor of hypotonia. So when you are going to see, there will be areflexia and the respiratory failure. But it's a transient thing. So you have to give the support and you have to give sometimes botulinum IVIG to support the child in order to get the infantile. But when the child is a toddler, the microbiome will look after the botulinum. Even if you get a injection of botulinum, that will be dealt by our supportive or our microbiome in the gut. So in the infantile stage, you might have botulism. So once you do differentiate that, in the genetic pathway is very important. The survival motor neuron is the SMN1 and 2 are the genetic tests that we will do. So obviously, when you have the SMN1 0 copies, it's confirmed SMA, 1 copy, 2 copies. Depending on that, you will diagnose SMA. So once you diagnose with SMN1, you will ask them to do the SMN2 genes also. Why? The SMN2 gene will decide whether this child is going to fall into the category 1, SMA type 1, 2, 3, or 4. That's very important. You can see SMN1 is usually in the clinical practice, we call it never sit type. SMN2, we call it never walk type. And SMN3, we call it able to walk, but with difficulties. SMN4 usually comes at the after age of 21 years, usually as an adult. So they will be able to walk with some waddling gait and certain weaknesses. So these are the 4 types that we usually highlight. So when you apply the SMN gene story into it, what will happen is you can see now if you have 1 copy of SMN1, it might fall here. But if you have more and more copies, more than 5 copies of SMN2 gene, then they will be having the less severe type of SMA type, or we call it adult type of SMA or SMA type 4. Clear? So therefore, SMN1 gene as well as SMN2 gene had to be done. And then SMN1 will decide the diagnosis and SMN2 will tell the factors about the severity of the disease. Am I clear? Right. So this is a child who is type 3 SMN. You can see the weakness of the child, the way child is keeping himself to him here. So weakness is obvious. You can see the weakness, type 3. So I think this is again the same thing. The life expectancy varies according to the type. So how we are going to manage the child? There are a lot of technological advances coming to support their mobility, their respiratory, their other kind of activities, then home adjustments. So these are out of this topic because this is the floppy infant diagnostic pathways. But when you are going to manage, that will be a different topic. Actually, these slides were for a 2-hour lecture. I think I have to stop at somewhere here. These are the elements that we are supposed to touch, and their sleep problems, how we are going to manage their scoliosis and other aspects, we'll deal in another day. And so that is all about SMA management. And just to have a look into this new drug or SMA, and you can see it's very expensive drug. How many millions? You see, even in USA, people can't afford. It's 2.1 million per injection. So I don't know whether that is feasible in the current context, and the drug is available and it's in the state of trialing at the moment. And very importantly, the support to the parents. This is a publication. What are the problems that the SMA parents will encounter and how we are going to support them, the family support. Those are HSMN is the second topic. If the muscle nerve head is okay, if the problem is in the nerve, we call it HSMA, hereditary sensory motor neuropathy. It can be 2 types, can be demyelinating type or it can be axonal type. So depending on that, there is a classification. I am not going into details, but importantly, that will be highlighted by the pescators and the nature of the lower limbs. You can see in the leg size and the pescators is an important feature that you will be able to judge whether we are dealing with HSMA. So that is actually not in the neonatal or infantile period. It will be much bigger children will come. So myasthenia, then the myasthenic type, I told you that is the third element in the nerve. So you have to know if it is anatomical. Now what happens in the myasthenia, the neuromuscular junction, we have the nerve electric. We have the muscle, it's again electric. In between, neuromuscular junction is a chemical part. So the electric activity had to be transferred to a chemical part through the antibodies, or sorry, through the receptor certain chemicals, and those chemicals should go and bind to start again the electrical. So in between 2 electrical activities, we have a chemical part. That is where the neuromuscular junction. So if there is an anatomical problem, you call it congenital myasthenia. The way it is operating compared to this myasthenia gravis, which is coming with the immune issue, where the antibodies are going and attacking our anatomy, is 2 different things. Again, that builds up on physiology side, and congenital myasthenias are built up on either the presynaptic, synaptic, or post-synaptic conditions under the congenital myasthenias, and the treatment modality obviously will be different. Understand, the same principle that we apply for the myasthenia gravis is not the same principles for the congenital myasthenia. It's a different topic altogether. So I will, but in the hypotonic baby, the transient myasthenia also need to be considered, and infantile botulism I told you. So usually they have predilection to the eyes and then to the bulbar regions, and they might have certain other skeletal and other features depending on the involved type. So myasthenia gravis I will skip, and then we will come down to the last part of that is the muscle, and we stop. So muscular causes of hypotonia, obviously congenital muscular dystrophy and congenital myotonic dystrophy is the conditions which we will consider under this age group. So therefore, again, that differentiation will come with the CPK levels and other neuromuscular activities. You can see Right. Then last part is the syndromes with hypotonia. Again, completely new topic, kind of a different topic. The trisomy 21 and Prader-Willi syndrome, and then Fragile X syndrome, Selvager syndromes, Angelman syndrome, and various other syndromes, and that will be considered under. So, and last but not least, you have to have the mind that there, by exclusion, there can be benign congenital hypotonia. That's another entity by exclusion. So management issues I am not going to touch at the moment, but to sum up all these things, this slide, very important, very important here. This is a recent publication on the diagnostic field. You can still say with all these genetic and other types of investigations, still the diagnosis is beyond 50%. So therefore, I think I'll reiterate back to you. This is the same scenario that we are going to demonstrate hypotonia. So in the process of history to understand, you should know what is hypotonia and how the hypotonia generated, what is the sensory element, what is the nerve sensory, then the spine, then the supraspinal level, and then the motor level, and then to maintain that balance, how the Golgi tendon is working in order to maintain the tone, in order to maintain our posture and the balance during the movement. Then as a clinician, you should be able to nicely demonstrate first by observation, first by then the manuals in a very comfortable, smooth manner without making a parent agitated or disturbed. So once you do the demonstration of hypotonia, the next step is that you elicit the weakness. By eliciting weakness, you differentiated them into two elements, whether the hypotonia strong or hypotonia weak. So if it is a hypotonia strong, of course, the upstairs problems of the brain and the spinal cord. So that list, of course, differently managed. And if it is a lower motor neuron hypotonia weak, of course, we have to see what elements is involved: nerve, head, nerve, neuromuscular junction, or the muscle. Or whether it's a transient one because of the mother is bringing something created atmosphere or not. Then we are the acquired things like botulinum, toxin, and other things. Am I clear to you? I think that is the diagnostic approach to Floppy Baby. I think I have exactly covered it in 1 hour. And it's, I think, hope that you will be able to really analyze a child to your best wishes to you. Thank you for the opportunity.
Thank you very much, sir, for your very informative lecture. Very important clinical aspects were discussed here. I would like to invite Dr. Sudath Fernando to present Dr. Anuruddha Padeniya with a token of appreciation for his valuable lecture.